From the JAMA Network, this is JAMA Cardiology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA Cardiology.
Hello and welcome to our listeners around the world. You're listening to JAMA Cardiology Author Interviews. Thanks for joining us. My name is Anne-Marie Navar. I'm a Deputy Editor at JAMA Cardiology, and I'm here with Dr. Dan Jones from the University of Mississippi Medical Center and Dr. Tom Gaziano from Brigham and Women's Hospital and Harvard Medical School. Dr. Gaziano, Dr. Jones, thank you so much for joining us today.
Thank you, Dr. Navar.
Privilege. Thank you.
So we were excited to publish two manuscripts in JAMA Cardiology recently, both focusing on population-level interventions to reduce sodium intake and their association or resultant effects on cardiovascular disease and cardiovascular outcomes. Dr. Gaziano, you published a really interesting analysis about what happened in South Africa as a result of legislation for reducing sodium consumption. Can you tell us a little bit about the Halsey cohort and what you found?
Yes, so the Halsey cohort is a group of about 5,000 men and women over the age of 40. They are part of a cohort of a series of studies funded by the National Institute of Aging to look at long-term aging in different countries throughout the world, one of 16 different sites. This particular cohort is in the northeast of South Africa, a sort of semi-rural population of predominantly Black Africans in South Africa. And they've been followed since 2014. And in 2013, South Africa introduced legislation to reduce sodium in 13 different food categories. This was a pretty significant intervention. They were the first country to do that many different food categories, and one of only 4 in the world to set targets on more than 5 different food categories to reduce sodium in those different products. The first date was 2016 that industries in those different categories, which includes like potato chips, soups, other processed foods like bouillon or other stock, and breads, to reduce them by about 40 or 50% by 2016. And then in 2019, to reduce it by anywhere from another 5 to 40% in those different categories. There was no set evaluation by the government when they instituted the policy. So we were lucky that we had collected urine samples in 2014, 2018, and 2020 in over 1,000 of these 5,000 aging South Africans. And we looked at urine sodium as a marker for sodium intake using a spot urine analysis. And we saw over the course of those 3 different times, there was reductions in sodium as well as reductions in blood pressure.
Thanks for the summary of a really interesting finding. We paired this in JAMA Cardiology with another manuscript. The second manuscript was called Effective Salt Substitution in People with a History of Stroke on Recurrence and Death. And the manuscript that we published was a secondary analysis of the SAS trial. That trial was initially published in 2021 in the New England Journal, and it was a cluster randomized intervention in rural China where different villages were randomly assigned to using salt substitute with 75% sodium chloride and 25% potassium chloride versus a control group which did not have any salt substitution. They had normal sodium chloride salt. And in the primary manuscript, the findings were that there was a reduction overall in the rates of stroke, major cardiovascular events, and all-cause death. What we published was led by Dr. Ding and Dr. Yan, and this was a secondary analysis looking at the effect of salt substitution in people with a prior history of stroke. So presumably a group of people at the highest risk of recurrent stroke. And the findings were that amongst people with a prior stroke, there was a 14% reduction in the risk of recurrent stroke and a 12% reduction in mortality in those who lived in villages randomized to salt substitution. So I want to start with Dr. Jones. You've spent a lot of your career and really been a leader in helping us understand the role of dietary sodium in hypertension and cardiovascular outcomes. My first question for you is, were you surprised by the results of either of these studies? And what was your initial reaction?
So, Anne-Marie, thanks so much for the chance to discuss these two really important studies. And as you know, I've been thinking about dietary sodium for a long time. We've had strong evidence in individuals that lowering the sodium intake and raising the potassium intake using salt substitutes is a good way to lower blood pressure. What we have not known are questions that are answered by these two studies. One, what happens at the population level when you do something to try to really reduce sodium in a general population? And then number two, even though we have strong evidence that reducing sodium reduces blood pressure, we've not had firm evidence from what we call hard endpoint clinical trials to show that reduction of sodium actually reduces cardiovascular disease events. So for convenience, I refer to the two studies as the South Africa study and the China study. And so the study done in South Africa looks at one bookend for important information in dietary sodium, and that is if a government reduces in a mandatory way the amount of sodium in processed foods, will blood pressure be lowered? And the answer is very clearly yes. And then the study done in China answers a question at the very other end of the spectrum, and that is in people who have already experienced the stroke, who have cardiovascular disease already, so are at very high risk for another cardiovascular event. Does reducing sodium in the diet prevent or reduce the risk of another stroke? And the answer is a resounding yes. Two really important bookends studies in regard to dietary sodium.
The South Africa legislation focused on limiting the amount of sodium in food, whereas the intervention in China focused on substituting part of the sodium chloride with potassium chloride. What would be your message for policymakers who are trying to think about different interventions and what strategies might work, and what are some of the contextual factors around geographic food intake that might help inform which one of these two strategies or combination of might be the best bet?
I think that one big answer is that you may need an all the above strategy. We know that, first of all, controlling blood pressure can be challenging. Less than 20% of the world's population has it controlled. That's with dietary, lifestyle, medications, et cetera. And so this is a really big problem, and we need to look at different ways to do that. And for a country to be able to reduce sodium in its population, I think there are key things. And one, this is just in your question, is it depends on where the salt comes from. And my understanding in the review of the Chinese literature is that a lot of the salt in China comes at the table or in the cooking process. And so any reductions or changes in processed food is going to have a limited effect on that. In South Africa, it's about 55% of the sodium consumption comes through processed foods. So both policies in this case would work. The reductions in processed food and the legislation on that would affect 55% of the source of sodium. But salt substitutions and other methods that people may use when adding salt in the cooking process or at the table would also work. So I think both of these are necessary, and for each country to sort of know where the major sources of sodium are for the population. Number one, prior to introducing policy, and then two, making sure that both of those potentially are available or on the table for policy setting.
Now, these were both population health level interventions, but I'm curious if we can take away any individual level points, particularly for clinicians and those of us who are advising patients about sodium reduction. I was struck that there was still a pretty high estimate of sodium intake in the Halsey cohort, even after the salt reduction, but we still saw blood pressure reduction. Maybe, Dan, what kind of magnitude of sodium reduction should we really be targeting at a population level? And maybe is that different than what we should be recommending at an individual level?
Yeah, so the American Heart Association recommends for people with heart failure, people with high blood pressure, people who have some form of cardiovascular disease or cardiovascular disease risk, recommends 1,500 milligrams per day, which would be about a teaspoon of salt a day. And some recommendations, including the U.S. national guidelines, recommend 2,300 milligrams, which is a little bit higher. Frankly, both are difficult to achieve in most food environments around the world. It's a difficult thing to achieve. But here's what's important is wherever you begin, a reduction in sodium intake can have an important impact on blood pressure. And if you look at the data from either one of these studies, and you're not familiar with the population level effect of reducing blood pressure by a little bit, you may come away thinking, well, gee whiz, 1 to 2 or 3 millimeters of mercury decrease doesn't seem like much effect. But if you look at this impact on a population level, a 2 to 3 millimeter drop in blood pressure can have a huge impact on the prevalence and the incidence of cardiovascular disease events. And both of these studies give encouragement both for population policy and for individual clinicians. And let me be sure I point out that the study in China did use a potassium-based salt substitute. And so they decreased the amount of sodium and increased the amount of potassium in the salt that was used in the home, if you want to call the potassium supplement in the sodium chloride salt. And that is an important issue for clinicians, especially in the US. Clinicians have been a little bit afraid of recommending potassium-based salt substitutes. But I think both the study in South Africa and the study in China give some evidence about safety for the use of potassium-based sodium substitutes.
Tom, just wondering if you have anything you'd like to add in terms of the magnitude of effect that you saw, both in terms of how much sodium was in the food, what the average sodium intake was, and how that corresponded to blood pressure changes.
Take first the sort of the magnitude of the effect in this particular policy. They did not predict overwhelming reductions in sodium. And I think that that's one thing to learn, that these are not drastic sort of changes in terms of the quality, the taste of the food that people might be concerned about. It appears to be the consumption is, that has not changed much in South Africa. But the reductions of about 1/3 of a gram of sodium per person per day, equal to a little less than a millimeter of blood pressure. And again, back to Dan's comments about that, that's very significant. I work with the World Heart Federation, and the global goals by the WHO or the World Health Organization is to reduce overall mortality by 30% by 2030 has been a goal that the UN's Sustainable Development Goals have been achieved at. And that's about a 3% reduction in mortality per year over the 10 years. And the United States has been achieving that for the last 50 years, although for the first time we've seen that level off. But for 3% reduction, and that's from everything from using thrombolytics, using PCI, bypass surgery, statins, blood pressure medications, all those things lead to 3%. And this 1 millimeter reduction will lead to about a 1% to 2% reduction in mortality. So that gets us to 1/3 of that, overall goal for the world. If people can do these small different things, and they add up over time. And so whether it's through potassium substitution or reduction in sodium consumption, both are very important. Getting at these millimeter, 2 millimeter, reductions, plus the medicines, plus any other lifestyle changes that are being introduced. So very significant and important because they're happening.
Dan, your editorial talks about the idea of a tipping point, and you highlight that we've actually known for many years the impact of salt reduction on blood pressure, increasing potassium consumption, but we haven't seen widespread policy changes that can lead to decreases at a population level outside of some of these individual country initiatives that we're talking about today. When you talk about a tipping point, if you had your way, what would you see change globally to try to get to that 3% that Tom's talking about?
So this is an important issue, and I tip my hat to the decision makers in South Africa. No one likes a government to impose anything on them. We all like our individual freedom. And so in governments around the world, they've taken the evidence that exists and has recommended, has advised, has asked that the food industry reduce sodium. They've asked individuals to reduce sodium. And I'll just say that the impact of the voluntary approach to reducing sodium has not been effective globally. A few countries have begun to, either through regulation or legislation, to impose changes in the food industry or to make changes in the availability of the type of flavoring products that are available for people to buy. I hope some of my friends from the U.S. Food and Drug Administration are listening to this today. I want to encourage them to consider these two studies as the tipping point for a decision to move toward mandatory changes in our food supply in the United States. And I would encourage the same for governments around the world. I do think that the study in South Africa demonstrates that a mandated approach to lowering sodium works. It lowers the sodium intake and it lowers blood pressure. And the China study, I think, demonstrates very, very clearly what policymakers have been wanting for a long time, and that is to really have the evidence that lowering sodium intake not only reduces blood pressure, it reduces cardiovascular events.
Thanks for a great call to action, and I too would hope that they're listening. Maybe we'll end with Tom. Thoughts on either future directions or any evidence that you have that we might be seeing some of these policy changes becoming more likely around the world?
Well, hopefully conversations like this and the publication of this literature will move that. Next year is a year at the UN where they're going to be dedicating the high-level meeting to chronic diseases and overall universal coverage and what policies are necessarily needed in the healthcare system and supportive policies, multi-sectoral, that will work for that. And I'm going to add on to what Dan mentioned earlier as well, that the UK has done some push for, quote, voluntary reformulation of food. And that's been quite a bit of work for them, continue to work with the regulators. This use in South Africa was a pretty simple policy. And I think people, they can see that it was relatively simple. People's liberties were not restricted, as Dan alluded to as well, that they might be fearful that people can go buy as many of these products as they want. It's just that generally people tend to buy what they need, a bag of potato chips or the bread that they're buying or the soup that they're getting. And this is sort of silent help that they're getting without even really noticing it. And those kinds of policies where it can be done quite simply, where people don't have to try to do major change. Lifestyle changes are hard. Make sure somebody exercises every day, watching what they're cooking or how they're doing it. This one just says you can buy the same things you normally doing. It's just going to be a little bit safer. We have policies in the FDA that restricting now in the news, like the red dye in food because it's harmful. Excess salt can be harmful. And so this is just another way for people to have that done without them having to think about it or making a significant effort for it. It's just quite a simple way. And we hope that globally there'll be attention to these simple measures that can be done by different countries. And many of these producers are transnational, and perhaps they'll think about not products just in one country, but products that they sell across many countries that might be beneficial. And that's another hope that we will see.
Thanks for a great summary of your work and commentary, Tom and Dan. I also want to thank Drs. Maoyi Tian and Li Jingyang for sharing their work from the SAS study with us at JAMA Cardiology. I'm Dr. Anne-Marie Navar. I've been speaking with Dr. Dan Jones and Dr. Tom Gaziano about a pair of articles regarding sodium reduction at the population level. You can find links to the articles in the episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.